And you are live.
Great, thank you. Good morning, everyone. We're just waiting for some of our colleagues who have been in a meeting to join us. So we're just hanging out here, getting ready for our work sessions. Just one work session today, and our language review that we will be working through with our analyst as well. We do have a work session on LD 1858. And that'll begin in just a couple of minutes. If anyone's just joining us or just tuning in on YouTube, we are just waiting out of a courtesy to our Republican colleagues who are meeting this morning, and we're having a more robust discussion than expected and aren't quite ready to join us yet. So although we have a quorum this morning, we did want to make sure that our colleagues were able to join us for the full presentation. So we're just going to hold on. Good morning, Representative Morris, Representative Blyer. Welcome. I think we'll get started now. Always happy to take a pause when we can, so that we have full representation on our committee. I will just take a point of personal privilege to say I really enjoy so much working on this committee and the collegial relationships that we have across the aisle on this committee, and the great work that we're able to get done for the people of Maine as a result. Such is not always the case, even sadly in the Maine legislature. So in any case, great to see you this morning, and let's get started in our usual manner with introductions of committee members, and we'll start with Representative Arford.
Thank you very much, Madam Chair. Good morning. I am Representative Poppy Arford, and I serve the community of Brunswick, Maine, District 49.
Representative Matheson. Oh, sorry, Representative Arford, did you want to finish? I
said half of, I do not serve the entire town of Brunswick. I share that with other wonderful representatives.
Okay, Representative Matheson, go ahead.
Thank you, Madam Chair. My name is Christy Matheson. I represent District 1, Kittery.
Representative Evans.
Thank you, Madam Chair. I am Representative Richard Evans, and I serve House District 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Orneville, and Lakeview. Thank you.
Thank you. And Representative Blyer, if you're able to introduce yourself, I saw you might be in a car.
Yes, Madam Chair, thank you very much. I am Representative Mark Blyer, and I represent District 22, which is all of Leamington and part of Buxton, Standish, and Limerick. I am here today via phone. My video will be off, but when it comes time to vote, I will be able to place my video on. Thank you.
Great.
We'll talk to you later.
Thank you, Representative Blyer. Representative Malorano.
Thank you. Good morning. My name is Gina Melorano. I represent House District 62, which is part of Auburn.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Morris.
Good morning. I'm State Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and Livermore.
Senator Brunner.
Thank you, Madam Chair. Good morning. I'm Stacey Brenner. I represent Senate District 30, which includes all of Gorham, part of Scarborough, and part of Buxton.
Representative Tepler.
Good morning. I am Denise Tepler. I represent House District number 54, which is all of the town of Topsom, and I serve as co-chair of the committee.
Great. And I'm Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook. And we are assisted today by our clerk, Edna Caford, and our committee analyst, Colleen McCarthy-Reed. And it's going to be her show today. Colleen, I'll have you present your analysis as we open the work session for LD 1858.
Great, thank you. I'm going to pull up. Thanks. So as Senator Sanborn said, the bill that we're working today is LD 1858. It's an act regarding delegating authority for services performed by emergency medical services personnel in healthcare facilities. As the bill's drafted, it authorizes licensed emergency medical services persons to provide medical services in healthcare facility settings that are not hospital settings under delegated authority if certain criteria are met. And the criteria that's set forth in the bill are that the medical service must be rendered in the person's capacity as an employee or a contracted agent of the healthcare facility, must be authorized by the healthcare facility, and must be delegated to that emergency medical services person by a licensed physician or surgeon in accordance with current law. Current law does have a provision that allows or authorizes persons licensed as emergency medical services personnel. It says that they are not prohibited from rendering medical services in a hospital setting if those services are rendered in their capacity as an employee authorized by the hospital and delegated by a physician or surgeon in accordance with provisions of statute under the licensing of physicians and surgeons. And I've summarized those two sections here. Under those provisions, physicians or surgeons that are licensed by either the Board of Osteopathic Medicine or the Board of Licensure in Medicine may delegate to the physicians or the surgeon's employees or support staff certain activities relating to medical care and treatment carried out by custom and usage when the activities are under the control of the physician or surgeon. The physician delegating these activities is legally liable for the activities of those individuals, and any individual in this relationship is considered the physician's agent. Members of the committee who were here in the 129th legislature may be familiar with when this provision was enacted as part of the committee's consideration of LD 2025. As I mentioned, as the bill's drafted, it would expand the settings in which EMS personnel may provide medical services under delegated authority to settings other than hospitals. The bill refers to healthcare facility settings, but does not provide further definition. So it was, the committee may want to think about what types of facilities are intended and possibly consider defining further what the term means. It was suggested in testimony of proponents that the change would help facilitate a proposed project in Jackman that's associated with a federally qualified health center. Others suggested the change could help address staff shortages in nursing homes and long-term care facilities. And I also posted in the electronic LD file a number of examples of different statutory definitions of healthcare facility in Maine law for different contexts. And if you wanted to look at those, we could pull those up later. So that's one issue, I think, for the committee to consider. And then I think the second issue that was raised in the testimony relates to the bill permitting EMS personnel acting in their capacity as both an employee and a contracted agent to provide services under delegated authority. And you did have some testimony from the director of Maine EMS and one of their board members raising some concerns about the language referring to contracted agents. And they did suggest that the committee consider removing that language. I think there are concerns primarily centered on the responsibility and oversight of those contracted entities. Their testimony described that when there's an employee relationship, they feel that the regulatory oversight is clear. The emergency services that would be provided by under the EMS license would be regulated by Maine EMS, and then any services provided as an employee in a hospital or other setting under delegated authority would be the responsibility of the licensed physician and then regulated by the Board of Licensure in Medicine. You know, using the term contracted agent, I think just raised some concerns for them about what oversight and regulatory authority there would be. In terms of some of the policy reasons that were brought up in the testimony from a number of individuals that testified both in person or virtually and provided written testimony, was asking you to think about what the proposal may do to help meet healthcare workforce needs, especially in rural areas. The Maine Municipal Association raised questions about the ability of municipalities to employ emergency medical services personnel and provide services to their community, and noted that the committee will need to weigh the needs of municipalities against the needs of healthcare facilities that may be in need of these services. And again, other questions were raised about if you do extend the ability of EMS personnel to work under delegated authority in healthcare settings other than hospitals, what level and oversight of oversight and supervision of those activities would take place in those healthcare settings? What licensing and oversight would be required of those healthcare facilities? and think about, how far that might go. The last thing I'd mention is the bill is drafted as an emergency. So if it moves forward and it's enacted, it would become effective once signed by the governor. You don't yet have any fiscal information on the bill. I note that you did receive some email communication from a representative of the federally qualified health center that's involved in the Jackman project that came in after the hearing. And I know that you have folks in the attendee space that are here to provide insight if the committee has any further questions. I'm happy to pull up some of those statutory definitions if you're interested in looking at or thinking about further defining the scope of what a healthcare facility is, and I can, as well as the current law and some of the law related to delegated authority. You want to look at that further as you're moving through your discussion. I guess I'll stop there, and I'm happy to answer any questions that you might have.
Thank you, Colleen. Are there questions for our analyst? Okay. Are there questions for attendees or additional information that the committee would like to seek from others who might be in attendance? Representative Arford.
We may not have the answer to this question now, but I'm going to pose it. I'm wondering how other states have handled or are currently handling in terms of proposed legislation like this, the situation that we're facing where the EMS personnel are now, we're proposing that they work outside of the hospital setting at other healthcare facilities. And I'm just wondering if we have any information on how other states are managing that in terms of oversight.
Okay. Colleen, do you have any information? And then I do see an attendee who put his hand up who could potentially answer that question. But I'll start with Colleen.
Sure. I am not familiar with any specific legislation in other states sort of related to your question, but the sort of the concept of delegated authority and the ability of licensed physicians to delegate authority to others under their control and supervision, which is in the current, licensing laws under Title 32, is fairly common in other states in terms of allowing physicians and surgeons to delegate certain activities to support staff or their employees. So that is common. What I don't know is the extent to which there might be carve-outs or specific language in those other state laws related to emergency medical, persons who are licensed as EMS. But I'm happy to provide to do some further research on that if the committee would like that.
Okay. And I'm going to bring in Jonathan Busco to hopefully give us some clarity on this.
Thank you. Not so much necessarily on other states, but this has been common practice in Maine for years. This piece was only added to the bill because of some concern about a letter that came from Maine EMS, but during his testimony, Director Hurley said that it was not Maine EMS's intention to intervene in cases where this has already existed. So in the state, there already are EMTs and paramedics in Maine who for decades have worked as medical assistants, which is the role this envisions, in outpatient settings. Outpatient offices, they work in nursing homes, they work in these places already. This piece was added just to clarify that when the original law was passed, that it wasn't intended to exclude that already existing practice, but rather to add the hospital setting on as well.
Okay. Representative Arford, do you have a follow-up for Dr.
Yeah,
Busco?
I want to apologize if my question was not as clear as it might have been, if I was actually more knowledgeable on this topic, which we're all learning about. What I'm specifically talking about is board oversight. For instance, if a patient had an issue with something that was done at an other healthcare facility, not a hospital, or not while the EMS personnel was operating under their normal scope of practice, I mean, in the ambulance environment, they were at an other healthcare facility, which board would they go to? Where would they go to register their complaint or their concerns? Because that was an issue brought up that we were being asked to address as we continue to look at this bill. That was the oversight I was referring to.
Okay, let's give Dr. Busco a chance to respond to that.
I can't speak specifically to other states. What I can say is that historically in this state, those complaints have gone against the physician delegating their practice. So there was a fairly substantial case in the early 2000s where there was concern about over-delegation, and that went to the Board of Medicine for review. And while under any of the delegated practice, I don't know that there's any specific board that looks at the delegee, because they are considered the literal extension of the delegator. However, there have been delegating physicians, and now PAs can do this as well, but who have gone before the board and ultimately are responsible as the delegating individuals to those delegees.
Okay. I think Representative Evans, go ahead.
Thank you, Madam Chair, and thank you, Mr. Busco, for being here. My question has to do with the contracted agents. Who provides oversight for the potential liabilities in those situations?
I would think it would fall under the same way. So, for example, I have a friend who is an EMT who's a medical assistant. She works for a traveler agency, and she gets sent around the state to work in doctor's offices as essentially as a traveling MA, but she has an EMS license. If she did something wrong, the liability would fall on the doctor's office she's working in, and then the delegated, if there was an error in a practice that was delegated to her, it would fall on the physician or PA who would delegate it to her. I imagine there may be some general liability for a company that hires people to do that kind of staffing, to act as contracted agents, but that would be more, I would think, general liability specific to their practice. It's going to be the office that is overseeing them and credentialing them to do what they're doing, and the physician who's delegating their practice to them.
I'd just like to follow up on that.
Go ahead.
If they are not affiliated or associated with the practice or hospital and acting as an independent contractor,
even then, they have no practice except that which is delegated to them by a physician or PA. So they would have to have that connection. They can't actually practice in any way independently on their own under the delegated practice statutes. So there's always going to be a physician responsible for, or again, a PA that was changed, I think, in 2013 or 15. But there's always someone with an Apex license who is legally responsible for their actions.
Thank you.
Okay. Are there any further questions for Dr. Busco? I am going to invite some other perspectives into the conversation because I think this is very helpful. But I want to take people one at a time so that we don't have sort of a panel debate during our work session, which I'm never a big fan of. So not seeing any additional questions for Dr. Busco. Dr. Busco, I'm going to thank you for your input and send you back to the attendee space. And I want to bring in Sam Hurley for his perspective on some of the questions we've been discussing. Good morning, Mr. Hurley. Can you provide us with your insight on some of the questions that our committee members have asked so far?
Absolutely, I'll be more than happy to. Thank you so much for having me. To Representative Arford's question, it's a mixed bag of tricks across the United States. So some states, EMS practice, no matter where it is regulated by the EMS office, and it diverts back to the Board of EMS or whatever entity they have as an oversight entity. Other states, it is similar to what we have in Maine, where if it's outside of 911 or traditional EMS interfacility, if it's outside of that realm, then it diverts to the other delegating body. So in Maine, one thing to note about in Maine is when EMS clinicians are functioning out in the hospital or in an urgent care, as Dr. Busco said, they can do that now, but they're not functioning as a paramedic or an EMT. They're functioning as a medical assistant. And so that's the nuance there, is that it's like them having a special driver's license. They're not, it doesn't matter that they have that special driver's license, they just have it. And it's kind of a benefit, but they don't actually use that special driver's license when they're working in these hospitals or clinics. They're practicing under delegated practice. But that goes to Representative Evans' question about where does the responsibility fall with these contracted agents, because we do regulate those entities like EMS agencies as an entity, and we regulate the licensees as a individual. And so that's where it gets nebulous with the contracted language. So an EMS clinician can go to work as an employee of a hospital, an urgent care, a doctor's office, wherever today, right now, but they are working as a medical assistant. And the regulation is very clear of who's responsible for that patient, that individual, and their work product. Whereas when we start adding contracted persons in there, it makes the water really murky, because then we have to decide, well, we regulate the entity and we regulate the licensee, but now they're functioning in a different space. Do we regulate here or not? And if they're exceeding their scope of practice, but they're still working for an EMS agency, are they in violation? And that's the murkiness that we are trying to avoid. If they're working as an employee, it's not a problem. So that's why we said we are not sure what this legislation will do. We think this just adds more confusion than actually benefits the system.
Mr. Hurley, I'm wondering if maybe we've just stumbled upon the confusion here, and why I felt during the public hearing and in reviewing that we were talking past that the various folks testifying were talking past each other a little bit. And so when you talk about contracting a contracted agent, it sounds like you're talking about a contract between, well, let me just give a hypothetical. A long-term care facility has a contract with Presque Isle EMS. And the contract says Presque Isle EMS practitioners, EMS licensed folks are going to serve as MAs when they're not on an active call. And so we'll supply you sort of as a temp agency, but it's the Presque Isle EMS, which is a regulated entity by the EMS board, that's contracting with the other healthcare facility that has physicians that work there and that are then supervising, or other Apex practitioners who are supervising the medical assistant / EMS provider. But because the contract is with a licensed entity, that's the confusing part. Have I described the issue correctly?
Yes, that's where it gets confusing for us. If they contract with XYZ staffing agency and they just so happen to provide staff, that's not the problem. It's with EMS agencies. That's where, when are they functioning in EMS roles? When are they functioning in medical assistant roles? That's where it gets really confusing for us.
Because effectively the Presque Isle EMS agency is then paying their employee to do non-EMS related tasks. That's sort of the crux of the issue?
Well, they're paying them to do EMS tasks and medical assistant tasks. And what is a medical assistant task and what's a EMS task? Because if they're paying them to function as a medical assistant, and then if there's an emergency, function as a paramedic, when does that role and regulation change? When do we start regulating and the delegating go away? That's the problem.
I think I'm starting to understand why I felt like folks were talking past each other, because I think Dr. Busco was imagining a traveling agency that was a non-regulated, or not regulated by EMS, but some other sort of temp agency, which is allowed today. Okay. I think that's very helpful. I do think there's a third possibility, which is that there may be some specific relationship, as we heard about in Jackman, where there's a specific sort of intentional pilot project between a number of organizations. Can you speak to that issue and whether current law makes clear that that's okay and how to do it?
Yeah, so the Jackman pilot project was proposed by Northeast Mobile Health Services and is being led by Dr. Busco. There wasn't a carve out within our regulations of how this relationship would work. So we've invested hundreds of hours in defining that as part of a pilot program. So Maine EMS has in statute the capacity to create pilot programs for a 3-year period for us to figure out how to make this work. And what we decided is, because the paramedics functioning in Jackman are licensees provided by Northeast Mobile Health Services, that we would give them an expanded scope so they could do more things that could be delegated to them. But we would regulate the scope of things, so they can't do neurosurgery in Jackman. We wouldn't want that happening. I don't think anyone wants that happening. But they could do suturing, which is typically not done by EMS clinicians. They could do nail truffulation, which is putting a hole in your nail when you slam it in the door and you have something underneath your nail. They could do some of these advanced skills, but we limited the scope to protect the patient's safety because we oversaw the EMS agency as a whole and their requirement to protect patient safety, and we saw the clinicians. So they would be delegating, but we limited the scope of what could be delegated to them because they were functioning under an EMS agency. So we did make sure this could happen, and we made sure that we did it safely. But that was the whole. We invested hours and hours and hours making sure this was a safe project with quality assurance metrics and other things that were built into this process. So we did accommodate it. We are looking at it. They haven't started yet, so we don't really have any data to say how do we go from here to potentially putting something in law or statute to allow for it. But I think this is premature to get ahead of ourselves before we figure out how this is actually going to work if they haven't started yet.
Okay, that's helpful. Let me ask one more question that I think will help the committee, which is that there's testimony from Dr. Busco that the unintended consequence of our 2019 statute that explicitly allows for EMS providers to operate as employees of hospitals has the unintended consequence of suggesting that they are not allowed to become employees of other types of healthcare facilities as medical assistants. Can you speak to that piece? Because I thought I understood you to say that, of course they can. It's just like you have an extra license and you just aren't taking a job in that regard, or you're working your other job where you're using a different sort of permission structure rather than your EMS license. So can you speak to why the 2019 law shouldn't be expanded, just to be clear on that employee relationship, that you are allowed to go be an employee somewhere else?
So the Maine Board of EMS has interpreted that law to mean that you can work in other healthcare facilities. We are not opposed to you clarifying that that means other facilities. The problem is we need other healthcare facilities needs to be defined more of what does that mean? It, you know, what does other healthcare facility mean? And we just want to make sure that if someone's working in a nursing home, we want to make sure that if we go into a nursing home and a doctor tells us to do something, Maine EMS can still have authority to say, no, they're functioning as a paramedic right now because they're on a 911 call. That doctor can't just say, oh, do this because I think you need to do it. Like, he or she needs to do that skill themselves, and we can support within our scope. But we want to just make sure that we're falling within the scope that we have defined by the board based on the training that these EMS clinicians have received. So, you know, we wouldn't be wholly opposed to you adding, you know, some language around other facilities that these people could work in, but the board has interpreted this very broadly. And for example, I work in an urgent care myself. Like, you know, this is, and Dr. Busco gave multiple examples of people working in other clinics and the person floating around as an MA. We have interpreted it very broadly to mean other healthcare facilities. And so I don't think we would be wholly opposed to you adding some clarifying language as long as it's defined.
Okay, that's really helpful. I think we're getting closer to an understanding. I've certainly learned a lot today in better understanding this issue. Are there additional questions for Mr. Hurley before I move him back through cyberspace? All right, I don't see any. So thank you very much for helping us sort through this. Okay, I am going to bring in Charlie Dingman as well. Good morning, Mr. Dingman.
Good morning.
And yeah, go ahead and weigh in on the topics we've been discussing.
So thank you for the opportunity, and I apologize that Penobscot Community Healthcare is sort of coming late to the conversation. And I think what I would like to emphasize, we very much respect Mr. Hurley's concerns about the difficulty of sort of assessing all of the unintended consequences and potential of a very broad definition of health facilities. The other problem for the Jackman project is that health facility may not be the right term for the setting that's envisioned here. And so what I've been thinking about since last night is, potentially one way to work through this to let the Jackman program clearly move ahead would be to specifically define that setting, which EMS is already very familiar with, and I think we could probably work out language that makes sense to everyone, and leave the broader question for further development. And just to explain a little bit, there is not necessarily a healthcare facility that will be the setting where the EMS person will be providing these extended rural health services in the Jackman project. There will be a delegating physician or physician assistant involved through telehealth. They will be based at St. Joseph Hospital. But if we call this location where the EMS person is providing services a hospital setting, we tremendously complicate both the reimbursement and the regulatory framework for this project. And that has not been what the parties have envisioned. This is there is a HRSA grant for this project. There are also multiple entities involved in sort of trying to put pieces together to make this work in the Jackman area. Penobscot Community Healthcare is the grantee and the leader of the project, but does not anticipate being part of the project on an ongoing basis. So saying federally qualified health facilities, for example, doesn't work because there won't necessarily be an FQHC in the mix going forward. There will be, Northeast Mobile Health will be involved, and as Mr. Hurley points out, they are regulated by the EMS board, and there will be physicians and physician assistants operating through telemedicine from St. Joseph's Hospital, and they will have authority and responsibility as the delegators to the EMS persons, but it will not be their setting where this is taking place. So what I sketched out last night, have not had a chance to talk to all of the parties here, is a description of this specific project, which could be built into section 85 sub 7 and would be limited to that arrangement. And to Mr. Hurley's point in the chat, we could certainly work on that language to make sure that it is not outside what Maine EMS has become familiar with during its work on the Jackman project, and just make sure that specific kind of arrangement is within scope for both the EMS, from the EMS folks, and that they would clearly be subject to the authority of a physician or physician assistant. So that's sort of the direction that we would certainly be comfortable with if it works for others interested. And we recognize there are others who've testified who are interested in other potential applications of this language. But since those are not the subject of, as Mr. Hurley said, EMS has spent hundreds of hours. PCHC has spent many hundreds of hours on this, as has St. Joseph's and Northeast Mobile Health. It's a very complicated project to pull together, and we would like to be sure that it does not get roadblocked inadvertently by language that, as Dr. Busco pointed out, is language that was intended to facilitate something a couple of years ago that kind of introduced the question of where the lines are.
Thank you, Mr. Dingman. I think I understand this better. Oh, I see Representative Evans' hand up. So go ahead, Representative Evans.
Thank you, Madam Chair. Thank you, Mr. Dingman. One question. Where do you draw the line, or has the line been drawn when someone is acting as an EMS personnel versus a medical assistant? How do you sort that out?
I think it's important to sort that out. I am not the best person to explain those nuances. Several of my colleagues at Kozak and Geyer have been deeply involved in these negotiations, but I have not. My general understanding is that the model here is that the EMS personnel are acting as medical assistants through delegated authority and not as EMS personnel. But as Mr. Hurley points out, because of the complexity of this arrangement, some of those lines are a little hard for everyone involved to be comfortable with, and that's what I think we need to hammer out in a way that doesn't unnecessarily erect an obstacle to the project moving forward. And as Mr. Hurley said, I think everyone wants it to move forward. It's just a matter of clearing up these questions.
Okay, thank you very much.
Representative Tepler.
Thank you, Madam Chair. I just want to sort of give a synopsis of my understanding of what the issue is and sort of then think about how we move towards a resolution of that. So as I understand it, part of the problem here is that the contract for work is with an EMS agency. And yet the people who are participating in that contract are not working specifically as EMS agents. They're working as MAs, medical assistants. And so we have a problem with who actually has oversight and where that line is between EMS and medical assistant. And this committee probably cannot resolve that problem without a great deal of help from the participants in those contracts and those who have oversight of them. So that's sort of my synopsis of my understanding of where the lines are.
So let me see if I can summarize it somewhat differently. And I think all three of the folks that we have brought in have been really helpful in helping me understand this, and for the committee's understanding and the folks in the room as well. I mean, we're not going to move to a vote on this bill today. There's more work to be done here. So, but here's how I would summarize it. I think that there is a question about whether the Jackman pilot project can go forward without us changing the statute in some way to clarify things. So there's sort of the pilot project issue is one issue. And then I think there's a second issue about individuals who have second jobs, is how I will sort of describe it. And whether inadvertently in the 2019 statute, we made it seem as though individuals couldn't get second jobs at certain types of facilities, but could at other types of facilities as medical assistants. And certainly that wasn't the intent, as I imagine it, particularly with the shortage in healthcare staffing. So I'm convinced that we probably do need to pass a bill, but probably not the one in front of us. And so what I would like to propose is that the folks who've spoken to us today, and also Kate Zimmerman, who I do see your hand up, but I'm not going to bring you in because we're gonna move forward and ask that you folks have discussions outside of this public forum, and see if you can't hammer out the solution to those two pieces that I've identified, which I think may be two different solutions, and there may need to be sort of even a carve out in the statute with regard to a pilot project, and that's possible to do. So if we could ask the folks who are much more deeply in the weeds and have already spent hundreds of hours, as you testified to, thinking about this, to spend, let's say, 10 days or so working through this and bring us back a proposal. So I think that would be on the Tuesday, 2 weeks from now. That would be very, very helpful for the committee, I think, and would allow us to proceed. So I'm going to throw that out there to my fellow members of the committee and see if anyone wants to add anything, if anybody sees another issue that we want to task this group with considering, other than the issue of the pilot project and the second jobs. All right, I don't see any committee members with hands up. So I'm going to move Mr. Dingman back into the attendee space. And while he is headed through the wormhole, I'm going to ask the committee if there's any further discussion on this bill, or whether we're ready to move to a tabling motion. And I don't see any hands up. So Representative Tepler, go ahead.
Thank you, Madam Chair. I move that we table this bill for further work.
All right. Is there a second?
Second.
Seconded by Representative Evans. And I suspect this is going to be a unanimous vote. So rather than taking a roll call, we will put our hands in the digital screen. Representative Brooks, can you put your physical hand up for me? Okay, great. So it is unanimous of those present to table the bill. So thank you to everyone who was here to help us sort out that difficult bill. Sometimes the ones that only change 2 words in the statute are actually the hardest ones to sort out. So thank you to those folks, and thanks in advance for the conversations that you'll have together and bring us back something that's hopefully workable. Great. Next, we have a series of language reviews. I will let interested parties know that we are going to hold off on the language review for LD 1776 pending some further committee discussion. That will probably take place on Tuesday. So we're going to hold off on that, and I'll have Colleen lead us through the other language reviews that we have on our docket.
Okay, great. So we're going to review 4 bills that the committee previously voted. I'll pull up the first one. The first one is LD 1815. And I inadvertently sent out an earlier version of it, but I corrected it and sent it out to the interested parties. This is the correct version that the committee voted on. This was a bill that was brought forward by the Bureau of Insurance to revise certain financial regulatory provisions of the Maine Insurance Code to be consistent with model laws from the NAIC. The committee voted to make 2 changes. One, to add an emergency preamble and emergency clause to the bill, because as you heard in testimony, there are some timing requirements for adopting these changes that would affect Unum's business. And because Unum is domiciled in Maine, if we adopt these group capital standards that apply, then they will be able to use those standards rather than any standards that would be adopted by the European Union pursuant to covered agreements between the US and the EU and the UK. And those agreements or these standards need to be in place by September in order to make that happen. So you voted to add the emergency preamble to hopefully ensure that the bill will be enacted prior to that date. So if it moves forward with the emergency preamble, it will become effective upon the governor's signature. And then the second amendment was something that was suggested by Mr. Garrity on behalf of the American Property Casualty Insurance Association to add back into the language a provision that was included in the NAIC model that had been taken out in the drafting process. And so this language will be added back in. We've added it as its own sort of paragraph, and it's been redrafted slightly, but it provides, again, to be consistent with what the NAIC model is, that any group capital calculation or liquidity stress test of an insurance holding company information, insurance holding company system, that those ratios, stress tests, and any results and supporting disclosures are not a means to rank any insurers or insurance holding company systems. So that's the second amendment to the bill, and it was a unanimous vote of the committee. I think you might be.
Sorry, everyone.
Oh, that's okay.
I got myself muted. Are there any comments on Colleen's analysis or amended draft? I don't see any, so I'll invite you to go on to the next one.
Great. The one thing I'll mention about this bill, a separate provision that was in the original bill would make certain information related to insurance holding companies confidential. So we'll have to go through an additional review by the Judiciary Committee before it's reported out. just to remind you about that. So you won't see it on the calendar on next week. But I'll keep you updated on that process.
Fortunately, you have an inside track
I
on
do,
reviewing
which is
things
great.
in the
Yes.
Judiciary Committee.
It should make it go smoothly, I hope.
Yes.
The next one is LD 1837. This was also a unanimous vote of the committee. This bill is an act to clarify the appeals process for decisions related to the Maine health insurance marketplace. And the bill would provide that appeals of decisions of the marketplace are made to the federal government, the Federal Department of Health and Human Services, which is the process set forth under the rules for state-based marketplaces, rather than subject to judicial review pursuant to the Maine Administrative Procedures Act, which is the regular practice for sort of final agency actions can be appealed to Maine Superior Court pursuant to Rule 80C of the Rules of Civil Procedure. So this bill is intended to clarify that appeals follow the sort of the federal process that's laid out for state-based marketplaces. So there were two changes that the committee voted to add as an amendment to LD 1837. One is an emergency preamble and an emergency clause, so that the bill will become effective, assuming it is enacted upon the governor's signature, so that the provisions would apply to decisions that are pending, subject to appeal. And then the second change is this language here, an application provision that says that the changes in the act apply to any decision of the marketplace made prior to the effective date that may be appealed to DHHS. So essentially saying that any decisions that the marketplace has made for this new, their initial open enrollment period related to eligibility for coverage under the state-based marketplace or any other decisions, that they also can be appealed through this process, rather than that's set forth in the bill, rather than the potential for pursuing the second avenue for judicial review. So it will apply to both decisions made prior to the effective date of the legislation, and then prospectively moving forward, the provisions about how decisions are appealed would be in place. So that's LD 1837.
I don't see any hands up, so go ahead.
Great. I'll go to the next one. The next one is LD 1798. This was the bill related to health insurance coverage for certain adults with disabilities. This was the bill that would mandate an offer of coverage for dependent children with a disability, regardless of their age. And you had seen a prior version of this amendment, but had made some additional changes when you voted on the bill. One of which was to remove the emergency clause and the emergency preamble from the legislation. So that has been taken out. And then it's just clarifying some language further related to the definition of a dependent child. So sections 1 and 2 govern the offer of coverage for individual health insurance policies. And you'll recall that you also made a change to the definition of disability to ensure that disability means a physical, mental, intellectual, or developmental disability that renders someone incapable of sustaining employment. Subsection 2, you clarified that the insurer must offer coverage for at the option of the policyholder for a dependent child with a disability, again, regardless of their age. Sections 3 and 4 cover the group insurance policy context. And it's really the tracks the same language that I just noted in sections 1 and 2. Sections 5 and 6 govern health maintenance organization contracts, both individual and group contracts. with the same language. And then the last sections 7 and 8 relate to carriers offering health plans subject to the requirements of the Federal Affordable Care Act. And here, there were no existing, in the original language that you looked at, they didn't carry forward the same definitions of dependent child and disability that were in the previous sections. So I've just redrafted it to include those definitions and cross-reference the appropriate definition of what a dependent child is. And I'll just note that the current law defines a dependent child as a child of a parent or someone covered under a policyholder in an individual health insurance policy, or the child of a parent covered under a group policy. So that's LD 1798. And as I mentioned, it would strip off the emergency preamble and the emergency clause from the bill as well.
Okay. Are there any questions about that? I don't see any.
Great. The last one is LD 1783. This was the bill that related to what I guess we're calling them copay accumulator programs and other financial assistance programs that individuals might be eligible for related to prescription drug coverage. The committee voted at the work session to more closely track the model legislation of the National Conference of Insurance Legislators. So the language has been redrafted to more closely track that legislation. Essentially, the sort of this substantive change from the original bill are really in, compared to what was in the original bill, are in paragraphs B and C. Paragraph B adds a requirement that the third party that pays any amount or portion of the amount of any cost sharing or out-of-pocket expense on behalf of the covered person for a covered prescription drug must notify the covered person prior to the acceptance of the financial assistance of the total amount of the assistance available, the duration for which it's available, and also prohibits that third party from conditioning the assistance on enrollment in a specific health plan or type of health plan to the extent permitted under federal law. And then paragraph C adds language related to the interplay between this provision and individuals who have a health savings account in conjunction with a high deductible health plan. And this is the language that was included in the NCOIL model to preserve, or it would say that with respect to a high deductible health plan offered for use with the health savings account, if the application of these provisions would result in ineligibility for that health savings account, the section applies only with respect to the deductible after the covered person has satisfied the minimum deductible, unless if there are services or items that are determined to be preventive care pursuant to the federal regulations under the Internal Revenue Code, the requirements of the provision can apply. So that's the language. It applies to policies or prescription drug benefits provided pursuant to policies on or after January 1 of 2023. That was in the original legislation as well. That's LD 1783. And I think I saw a hand come up.
Yep, Senator
Yeah.
Stewart, go ahead.
Thank you, Madam Chair. So where this bill's model language is coming from NCOIL, there's specifically with regard to section B, since the initial vote and sort of the adoption of that NCOIL model, I and maybe some others on the committee have gotten some feedback from some stakeholders that language might be problematic to the extent that there are some programs that are offered that are sort of automatically applied that help reduce costs for a certain pharmaceuticals, the big one being insulin, and that we may want to take another look at that language that's used in order to not inadvertently prevent those programs from being applied currently. That was the feedback. I know that this is I believe it was a unanimous report I just wanted to bring that to everybody's attention. That way we could have a conversation about it and maybe get some more feedback from stakeholders before we do something that might not be what we're hoping to accomplish.
Yeah, Senator Stewart, I received that same feedback, but I think the greater risk here, and I assume the reason or a reason why NCOIL inserted this is that there seems to be sort of a vagary to these pharma-based coupon programs where the people who receive them just kind of pray every time they go to get their prescription refilled that they'll still get their copay assistance, and then it just disappears. Poof! At some point, they get to the counter and there's no copay assistance. Because pharma won whatever price manipulation battle was going on with whatever formulary they were trying to get a better spot on, or whatever it is. So that same issue was raised to me by some of the patient groups who are spokespeople in these cases, sometimes for the pharmaceutical manufacturers who manufacture the medicine on which their members depend. And my response was, I think they can figure out how to give you advance notice about how long you're going to get coupons for. So that was my sense of it, was just, this seems like a consumer protection piece that makes good sense and is a balance with the other side of the equation, which is that these coupons are sort of they're a little bit dangerous, I guess I would say. And they're certainly dangerous if the consumer finds them unpredictable. So I don't want to create unintended consequences, and I totally agree with you. And I don't think I would have suggested this language had it not been in the NCOIL model. But where it is, it seemed like an additional good protection that we could put in place to have a little bit more transparency on these programs. And I'll call on Representative Tepler and get her thoughts.
It seems to me that the insulin out-of-pocket insulin cost cap that we have would be enough in most cases to take care of problems. I guess I don't understand in the case of insulin what would be going on, unless it's about brand name, higher tiered items that might be more convenient. And that would be the only issue I can see.
Senator Stewart?
Thanks. And it's not just insulin. From my understanding of the ones that are impacted, I don't have a comprehensive list of what other pharmaceuticals might be impacted by it. I guess more what I'm wondering now in sort of hindsight is if there's a way to incorporate those potential benefits and just have them be applied, or use language that would just do it right and not necessarily get in the way. I don't want to have, let me think about how to phrase this. If there's a way to sort of have both, right? If there's a way to say, if they say, look, that we've got a coupon, we could use it, except Maine has this law that says, well, we have to do something else first, and now we can't automatically apply it. Is there a way to just apply it and then still be able to have that, I don't know what you call it, data collection, I guess, going on in addition to it as well, for accumulation?
Yeah. And it's not data collection so much, maybe, I mean, I'm just trying to figure out where we get to. It's sort of notice, right? It's advanced notice to the consumer about whether this was a one-shot deal, or whether they're going to get this discount next month, or whether they're only going to get it, for 2 more periods of refills, or what it is going to look like. So I wonder if we put something in that says, that the third party payer has to let them know, within 7 days after having used the coupon, or, has to let them know within 30 days about whether the program, is going to continue and for how long or something like that. And again, that's still a data flow issue, right? I don't know how the third party even finds out about these patients. And I don't really understand exactly how these coupons all flow. And I think there are a bunch of different ways, right? You sometimes have to call the pharmaceutical company, apply for patient assistance, and then other times maybe your pharmacist does that for you, or some other patient advocacy group does it for you, or your physician does it for you. So I think there's just a lot of different ways that these things happen. So maybe giving some leeway on the time frame would make sense, rather than before getting the assistance, but maybe before getting the second round of assistance. It seems like there's an opportunity there somehow to thread the needle here. Representative Evans.
Thank you, Madam Chair. I see the issue as Senator Stewart presented it, and I also agree with you. We should put the onus back on the pharmaceutical company, and giving them, as a compromise, giving them a time to respond back to the patient may be a benefit, and keep things without having to change anything else. So you had mentioned 7 days. I would not exceed 10 days, but the onus should be on them to notify the patient. We could structure the language in that regard somehow. But if you want to go with 7 days, I'm okay with that too.
Yeah. It may be as simple as a pamphlet or something, right? That the pharmacist has that just describes the program, right? The pharmacist has a pamphlet. It tells you you're going to get 6 of these copay assistance, but there has to be, a pamphlet that the pharmacist has or something like that. And if there's just a pamphlet, then that's covered under, the immediate kind of notice piece. But I don't know, what's the sense of the committee? Because I do feel like this is the sort of thing. I had one right here. There's like a mail-in rebate that I got when I got my contact lenses most recently, right? And like, there's a pamphlet that tells me how much the assistance is, and how much how long it's gonna last. It has that information in it, and my doctor gave me the pamphlet, and then I was able to get the rebate. So I don't know if we might be overcomplicating this in some way, perhaps at someone's request, and tying ourselves around the mast for it. I don't know. Representative Morris, what are you thinking?
Thank you, Madam Chair. Yes, I would agree with, I certainly concur with the concern raised by Senator Stewart on this, but I absolutely agree with you as well as Dr. Evans or Representative Evans.
Both.
Yeah, both. I know. We're in this setting, so we're supposed to call, even though doctor is probably a little more of a prouder accomplishment, I would think. But I think we did a good job with this law as far as getting it into the language that we want. I think that my biggest concerns were making sure people could still get the HSAs, as well as ensuring there was protection around ensuring that insurance rates weren't going to rise because of what we're trying to do here. But I also like the idea of the consumer protection with some disclosures as is laid out in this. But I also think if there's a way we can thread that needle to make it so that we're not having the unintended consequences of people losing out on certain rebate programs or something, I think that would be the best way to handle it, as you have stated it.
Okay. Representative Tepler?
Thank you, Madam Chair. And by and large, I agree with what's been said. My only concern is I don't want to see people go to their pharmacist and get, and the word hooked is not quite the right word, but get accustomed to a medication or a form of delivery of a medication, which is going to become incredibly expensive and difficult for them some, 6 months later when it's an ongoing prescription. So that's, I don't want to see people get caught in that trap. And I'm even wondering, that's 6 months that they might get it at a better rate. And they've got the brochure that tells them it's only 6 months. But how do they make that decision? What's our best route for protecting them? Does knowing that they'll only get it for 6 months help them to decide? Or is it like they don't fully understand? Can you switch from that more convenient delivery method, let's say, to a less convenient one without an issue? So I have some hesitations even about the 7-day thing. I kind of like our original language, but I will go with the sense of the committee.
Representative Brooks?
Yes, I think the coupon programs, I know that in the past there was more availability, and like I won't make judgment on it, but samples in a doctor's office. And now it appears like if a doctor or a patient decide they want to try something new or different to them, if it's a brand name within the patent or even without the patent, there could be a coupon program. So that being said, I think the original language of the bill is really important and good. I think fine tuning it to help increase transparency on the patient's end and between the provider and the patient to keep people informed. Like, you don't want to get to the pharmacy counter and get an exorbitant price and say, I can't afford that. And then at the point of the pharmacy, them say, well, there's a program, let me help you with it, which is good, help me with it. Without that kind of knowledge as to how long, what's a fine print, how long will this last for? So I'm not opposed to having kind of fine tuning in the informed consent category to help improve communications.
Thanks, Representative Brooks. Senator Stewart?
Thanks, Madam Chair. I just wanted to say that I'm fine with, I think that language makes sense that's been thrown out. 7 days seems fine to me. And certainly I share those same concerns with Representative Tepler that, the goal of that is not to get them hooked in 7 days and then, pull the rug, but at least if you've got, 6 months or however long the program runs for, you can sort of make plans accordingly and talk with your doctor about, what makes sense to do next and how that's all going to work. So
Colleen, can you put the language back up for us for a second? So in order to change the language, this is going to be substantive. So we are going to have to move to reconsider, which is fine. And I'm going to suggest the words must notify the covered person prior to or within 7 days of the acceptance of the financial assistance.
Do you need a, Madam Chair?
Sure. I was kind of just throwing it out there to see if there was any comments on that phrasing. And maybe if Colleen has any comment on that phrasing or whether she thinks that captures what we're saying.
No, I think that was what I was thinking too. So.
Okay.
Good suggestion.
I like the idea of keeping the prior to in there. And then just kind of making it, optional prior to or within 7 days. Representative Brooks, go ahead.
I would just say that it might be helpful, and I don't. Again, this might get into some other categories of law, but it would be helpful for the provider's office to have some sort of a kind of heads up that this might be an issue going forward, but that's just me. Like just as far as I know, notification of the patient is primary and they're the decision makers, but I'm just wondering if maybe the provider's office might know in advance that this is something to discuss. That's just me.
Yeah, I think we get into a tricky situation when we start requiring too many different parties get involved here because of the complexities that are involved in our healthcare systems, unfortunately. But I do hear what you're saying on that, Representative Brooks. Okay, Senator Stewart, do you want to make a motion?
Sure. I'd move that we reconsider LD 1783.
Okay, is there a second? Seconded by Representative Evans. I anticipate this will be unanimous, so I think we can do it as a procedural vote with our hands in the window. All those in favor of the motion to reconsider? And it is unanimous of those present to reconsider. So next I will ask if there's a motion. Another motion. Senator Stewart.
Thank you, Madam Chair. I move that we amend Section B of the bill to read prior to, what did we say, or within 7 days. And
Great.
leave the rest the same. I think is that motion sufficient?
Sure. I'll have to pass as amended with the additional amendments. Is there a second? Representative Evans seconds the motion, and I'll have the clerk call the roll.
Thank you. Senator Sanborn?
Yes.
Senator Sanborn? Yes. Senator Brennan?
Yes.
Senator Stewart?
Yes.
Representative Tepler?
Yes.
Representative Tepler, yes. Representative Alford?
Yes.
Representative Alford, yes. Representative Blyer?
Yes.
Representative Blyer, yes. Representative Brooks?
Yes.
Representative Brooks, yes. Representative Connor? Representative Evans?
Yes.
Representative Evans, yes. Representative Madison?
Yes.
Representative Madison, yes. Representative Malavano?
Yes.
Representative Malavano, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Quinn? 11 committee members in the affirmative and 0 in the negative.
Thank you, Ms. Kayford. All right. And Colleen, do we have one more bill? I'm losing track.
We did not, because we
Okay.
were deferring 1776 until
Okay.
Tuesday, I think. Yeah.
Yep.
So that's it.
Great.
That's it for today. I'm hoping maybe we can connect about schedule.
Yep. We can do that right after this.
Okay, great.
Yep.
Perfect.
Yep. And so this is kind of an interesting trend that seems to have happened to a number of committees, is that there was a bit of a lull in referencing of bills for some reason a couple of weeks ago. And so we didn't have anything else available for us to have a public hearing on today. Another update for the committee, just so you know what the chairs have been discussing with Ms. McCarthy-Reed, is that we've been holding off on all of the bills related to mandate studies until we have all the mandate studies in from the Bureau. And Colleen, can you give us a quick update on whether they're all in?
Not quite yet. We're still waiting for the last ones. We've got 4 of the 5, but I'm hopeful we'll get the last one soon. It's on my list to double check with them on status, so I will be following up with them.
Thanks. And there is at least one other carryover bill that we do not have the report back for. That's one about therapeutic foster care homes that we don't have the report back yet on from the Bureau either, but are anticipating that within the next couple of weeks. So that's the reason why we've kind of run out of gas today on this Thursday. But we'll have lots more to do in the coming weeks. And we do have a number of public hearings scheduled in mid-February as well, with some of the later referenced bills. And so with that, I think we will adjourn for the day and enjoy your extra afternoon hours away from the legislature this afternoon. Thanks, everyone.